This is Steve Pearson at the Institute for Clinical and Economic Review. Thank you again for joining us. This is the fourth in our series of 5 webinars that we are holding on perspectives on cost-effectiveness thresholds in the United States. The earlier webinars, for those of you who were able to make them, kind of covered the broad philosophical approaches as kind of an overview of ways that people have thought about cost-effectiveness thresholds over time. And then we've had a couple of webinars that focus in on different ways of thinking about willingness to pay as one of the obviously major dominant paradigms for thinking about cost effectiveness and how you would find or set a threshold or threshold range. So today we're very happy to have Carl Claxton from the University of York, and he'll introduce himself briefly, focus on opportunity cost as an approach to cost effectiveness thresholds. And for responders, we're going to have Lou Garrison, and hopefully we'll get Anirban Basu. It was going to be Sean Sullivan, but he wasn't available at the last second. So we're going to have Anirban hopefully be able to take his place. So with that,
I'm here, Steve.
Oh, great. Anirban, thank you very much. Hang on, we're going to get to you and to Lou as soon as Carl has his chance to lead us on what I'm sure is going to be a completely dispassionate, dry textbook approach.
Absolutely,
Carl.
Steve. Oh. Got a problem with the slider, man. Are we good?
Have to go down to the
Okay. Yeah, so Carl Claxton, University of York, family member of NICE Appraisal Committee. I've now declared war on NICE. I now work more closely with our UK Department of Health and also the Gates Foundation. So, these are Steve's words, not mine. Fair price, fair access, and future innovation. And they were made real to me when I attended the absolutely magnificent CPAC meeting just last week. I really want to thank a couple of my colleagues who were not on this slide, but that's James Lomas, Jessica O'Halleck. They've had a real contribution to this slide deck and all the work that goes behind it. And it's a real privilege to work with young people with such excellent heads and excellent hearts. Also, a big thanks to Dave Van Ness, who shared a draft of his paper. So let's get started. What is a fair price? Well, first of all, we need to decide what healthcare is about. Why do we bother providing healthcare? There's lots of reasons, but maybe we could agree on one thing, that one of those reasons is health. That's why we pay for healthcare, because we want to improve health. If we want to improve health, we need to know how to measure it. So we need a measure of health that's going to capture impact you might have on survival and the quality in which you're going to survive in those years. Now, ideally, we want a measure that has some acquaintance with people's preferences. So you know what, if you don't like QALYs and quality adjusted life years, and I have to say QALY is a pretty ugly acronym, if you don't like them, then just think about another measure of health that's going to capture morbidity, mortality, and be associated with preference. It's going to look just like a QALY, but you don't need to call it a QALY. Call it anything you want. Let's imagine that green dot represents what's currently available in our plan. And somebody's offering us a new technology. I'm getting a problem. Could somebody help me slide advance, please? Can you show me how to do it?
I'll do it now.
Okay, thank you. So somebody's offering us a new drug, and it's going to deliver us 2 additional quality adjusted life years for every patient treated. I've never seen a drug like that in 13 years on a NICE committee, so we've been very optimistic here. At the price being charged, it's going to cost our healthcare system or our plan another £20,000. Is it worthwhile? Well, we can summarise it at £10,000 per QALY. To decide whether that's worthwhile, we need to know something else. Where is that £20,000 going to come from, and what are going to be the consequences elsewhere to other patients that we serve? Now, if we believe health opportunity costs, let's call it KH, of £20,000 per QALY, what we're saying is every £20,000 we have to find from existing commitments is going to lose us 1 quality adjusted life year somewhere else. Now, that's the way to say it if we're living in a single payer administrative budget healthcare system. But you know what? We might be a single payer but without a budget constraint, a bit like Medicare. What is it then? Well, then we need to ask the question, okay, what else could we have done with that £20,000? Maybe we're going to raise more taxes to get another £20,000, but what else could we have done with it with the existing technologies already available to us? So whether we've got a budget constraint or not, we need to think about what this looks like. What about a private plan? Maybe we don't need to worry about it in a private plan, but the truth of the matter is, if we decide to put this on the formulary, we're going to increase premium prices and some people are going to drop their coverage, and that's going to have some health effects. And we know something about the health effects of dropping your coverage. So whatever kind of healthcare system you're in, you need to understand your health opportunity costs if you're going to make a good decision. In this case, we gain 2 QALYs. What do we lose? We lose 1 QALY elsewhere. This is great. We improve health outcome overall. You can say the ICE is lower than the threshold if you really want to, but that's a pretty weird way of saying the benefits that we get exceed what we have to give up elsewhere. That's what it's all about. Let's imagine the manufacturer charges a little bit more for this product, as they should if they're rational, and now it's P-Star at £40,000. It's the same technology. 2 QALYs gained, guess what? At that price, we gain 2, we lose 2. It's all the same to me. We're right on the margin. This is the maximum we can afford to pay without doing damage to our healthcare system and the people that we serve. What if they oh yeah. So that represents the maximum. P-Star's the maximum. If the manufacturer was been very kind and only charged us 20,000, then that tells us something about the surplus that our healthcare system gains during patent protection. If we charge up to P-Star, there ain't no surplus left. We've given the entire value away to the patent holder. What if the manufacturer charges a bit more, and they do tend to do that? Well, now it's £30,000 per QALY. We can afford 20. What does that mean? The ICE is higher than threshold? That's not what it means. It means the benefits that we get from approving this product are less than what we're going to have to give up elsewhere. In other words, we gain 2 QALYs per patient. We lose 3 QALYs elsewhere. The net health benefit is negative. Saying it's not cost effective means that it reduces health overall. That's what it's about. You might say, okay, but what about the dollar value people place on these health effects? The consumption value. We've had 2 webinars on it. Absolutely. Let's chuck that in. Let's rescale everything. Let's imagine that the consumption value of health, V, that's £30,000 per QALY. We just multiply everything by 30,000. Guess what? Nothing changes. We're multiplying both sides of an inequality by a bigger number. I can change the consumption value of a QALY to £10 million and it will make no damn difference. P-Star is still the most we can afford to pay for this product under patent. So, we've dealt with what's a fair price, I hope. What is fair access? Well, let's examine that. In truth, there are different plans and different healthcare systems, and they've all got different Ks and different Vs. And the reason why they've got different Ks is because they've got different funding envelopes, right? They've got different Vs because they enroll different kinds of people. Now, what you're looking at here is a plan with a K of £30,000, a V of 60. So this is your Blue Cross Blue Shield, right? They've enrolled some pretty good risks and they've got deep pockets. Now, what if we decided that we were going to judge this new drug on the basis of the K and the V for Blue Cross Blue Shield? Well, you know what? We would say yes at price P-Star 1. That's the price for the Blue Cross guys and girls. But what would be the consequences for the other plans? Here we've got another plan. This is kind of your medium kind of plan. You know, it's a pretty big, you know, multinational corporation, but they ain't quite Blue Cross Blue Shield material. And here you've got a plan. This is for a small construction company. I imagine they're down in the valley in West Virginia, right? And they're desperately trying to keep their employees enrolled. And I think the company's called the Jonestown Company. And lately they ain't done much work on account of the economy and any rising premium, and they're going to have to dump it. What are the consequences? What are the consequences if we pick a K and a V that's too high? Have a look. Have a look at the implications for the plans. The implications are that the people in Plan 2 and Plan 3 are the ones that lose. They lose health and they lose consumption. They basically pay for Blue Cross Blue Shield with their health and out of their pocket. What would be a better solution? A better solution would be having a different price for each of these plans that reflects how much the enrollees can afford to pay. Now, I hear a few people in the manufacturing, or take Jens' point, not manufacturers, developers of new innovations, you know, And sometimes they kind of give the impression that, well, maybe the sun don't shine on us anymore because the bodies like ISA and NICE and all the rest of it. Well, I'll tell you what, let me take you by the hand and I'll walk you through the streets of London and maybe I'll show you something that's going to change your mind. This is what it looks like. This is patent protection. We pay the maximum. That's up to the K, not the V. We pay the maximum during patent. Patent lasts 15 years. We get zero value. You get it all. Patent expires. We claw some back because we get cheap generics and we switch. And in this case, where we set our approval threshold at opportunity costs, in this particular case, we get 50-50 when hell freezes over or the sun goes supernova and we all return to stardust. But you know what? I do have to quote Ice-T and Body Count, and I'm sorry for the cursing, but you know what? Shit ain't like that. This is what it looks like. This is the share of value. On the x-axis is, if you like, the approval threshold, the threshold that a body like NICE uses, and the red arrows indicate where NICE has been pushed to. The 15 is an empirical assessment of what their actual health opportunity costs are, and this is how the shares pan out. In this case, it's a scenario, 15 years left on patent, we're going to get small molecule generics, and we're going to discount at 3.5%. The UK Treasury makes us discount at 3.5%. To be fair, it's crazy. It should be 1.5%, but hey, I didn't win that argument. It might look a lot better for us from the healthcare system and consumers' point of view if there's only 10 years left. We get a bit more of the share, but notice this. Sorry, let's go back. In this case, when you approve at £30,000, you've given 100% of the long-term value away. Now, we don't know what the optimal share is to ensure that we do get future innovation, but we know two things. We know we can't give zero share and free ride, and we know we shouldn't give 100% because then we have lots of cakes, but we starve to death because we can't touch any of them. So what this is telling us is current arrangements are giving away more than 100% of the long-term value of the innovation. If we've got a little less patent life, we do a little bit better, but you know what? We're still giving it away at £40,000 per quality. This is a biologic. We ain't going to get a small molecule that's super cheap. We're going to get really expensive biosimilars. This is your antimicrobial resistance. This is where incidence is growing over time. So we get most of the benefit when the patent's expired. There's one thing I haven't put on here, and that is a high prevalence, low incidence disease, chronic disease. That's really bad. We're paying up front under patent, and we're never going to get our money back. Let me show you. We're working on some real examples, and I'm just going to show you one. And just to be clear, I picked the best one we've found, right? I didn't cherry pick this. This is the best one we've been able to look at. And guess what? We've given away absolutely all the value. So what we are doing is we are incentivizing future innovations, yeah, but ones that are profoundly unaffordable and will do damage. So we know we need an estimate of health opportunity costs. What do we know about it? Well, in the UK, we know quite a lot about it now. We've been working in this area for a long time. We understand something about the scale of health opportunity costs. We know something about the type, the mortality effects, survival effects, morbidity effects. We know where they're going to occur by disease, by age, by gender. We know something about the severity of disease in which we give up health, burden, absolute proportional. We know something about the effect that that has on the wider economy, both marketed and non-marketed productive activities. We also know something about the impact it's having on health inequality in the UK. We know something about the implications of affordability and the scale of budget impact. Yeah, we have to make some assumptions to link this to quality of life. Done a big elicitation exercise, and actually what we thought was true is true. Our assumptions are very conservative with respect to the health effects of changes in expenditure. We've re-estimated all this for all waves of data now, and we've also done it for other categories of expenditure, not just healthcare. We've done it for public health, and we're doing it for social care. And let me tell you, I'll tell you something, right. Cost per quality for public health expenditure, which was subject to a 25% cut over 5 years by our current government actually the cost per QALY for public health expenditure is less than £4,000 per QALY. We've just estimated it for social care. And social care has been starved of money, and the people who work in it get paid less than minimum wage. And you know what? The mortality effects of social care are massive. And it should be no surprise. If you keep people hydrated and fed, they don't die. It's a bigger bang than the last oncology drug I looked at. These are the results for the UK. These are the health consequences of something that's going to cost you £10 million, or if the Minister of Health gave you £10 million and asked the NHS to spend it. £10 million means a loss of 51 avoidable deaths, 233 life years, and you can see where the survival effects are biggest. The big hits are taken in cancer, circulatory, respiratory, and gastrointestinal disease. We also have big quality of life effects, because quality of life is actually the bigger burden in high-income countries. Where do we take the hits? We lose QALYs in respiratory disease, all those people with COPD. We take a big hit in neurological, and we take a massive hit in mental health.
Carl, can I ask you a quick question now, since I'm here at the table? I can. The consequences of 10 million, would the QALYs gained be the same as the QALYs lost?
Good question.
We're on the curve, because in the U.S. we often feel like we're out at the end of the curve where additional spending doesn't gain us much health. Maybe it doesn't lose us that much health either. But is it symmetrical or not?
Okay, so that's where the work on affordability with James Lomas comes in. So we've estimated a margin. We have estimated it over the range of variation in expenditure at a local level. And if you think about the range over which we're estimating, it's about £1 billion. So 10 million is marginal, man. Now, once we start to get to bigger numbers, yeah, it makes a difference, and we've been able to estimate it. So if you are talking about a bigger hit to the NHS, the thresholds are lower, the opportunity costs are higher. If you're talking about a big uplift, actually we're not getting proportionally quite as much help. Okay. But we can estimate that by splitting the sample.
So you would lose more by losing 10 million than you would gain by an additional 10 million.
Yeah, okay. Yeah. But 10 million as a number, all right, it's marginal.
Got it.
Okay. Right. If it was 10 billion, different story. I said that we knew something about the type of health. And this is a table, it's published, it's in a paper. You can see this is a sample of ICD codes of where NICE issued guidance. NICE was in the business of saying, hey, let's have some weights on burden of disease, proportionate shortfall, absolute. Let's include all these other things in the wider economy. Well, fine, if you want to do that, go right ahead. But we've got to do it sensibly, and we've got to do it consistently. And that means it ain't always going to be a winner. You're not going to win all the time. Sometimes you're a loser. The red indicates the average of what gets displaced in these categories, right? On the far right, if you really want to start a societal perspective, that's fine, as long as you're willing to say to people, actually, you'd be better off dead for the rest of society, because those red are all negative. They're all negative. One QALY gained in those ICD codes costs society dearly. And you know what? To get a bigger premium because of taking a societal perspective, you've got to be above the bold blue. It's not good enough for you to show that there are net benefits to wider society. You've got to do better than our existing healthcare system. So listen, it's up to you what you want to do, but if you're going to do it well. It's almost Janice, not quite. You've only got to do one thing well one time. Okay, what the scores on the doors? This is 10 years worth of data re-estimated. The red line is £15,000 per QALY. That is the number that our Department of Health and the Minister has signed off on. This is the way the Department of Health thinks about opportunity cost in all its policies and negotiates with Treasury in the spending review. We've just re-estimated it using a completely different approach to identification in our instruments, and we get the same damn answer. No matter what we do, we get the same answer. Now, I was going to say something about my daughters, but I'm not going to do it because actually I shouldn't. Language is important. Listen, previously, I'd have bet one testicle on us being right, and it's less than 15. Now, I'll perfectly happily bet the pair. It's not a really big bet because they're not useful anymore, and they sure as hell ain't an ornament. Okay, other estimates from other countries, similar story. Oh, it's the wrong deck. It's the wrong deck. It's on there. Is it okay? Can we take a minute to put the right deck in?
Oh, sure. As long as you can regale us with stories of your boat while people are waiting. Actually, while we're getting the further slide deck put up, apologies. Why don't we just see if Lou or Anirban have a question?
Yeah.
Maybe a question or a quick comment, because we're likely to be able to get the other slides up very shortly. Lou, do you have a comment or question?
Well, I'm not going to bet any testicles on this discussion. Anyway, I'll leave it at that for now. But no, I mean, I think Carl. I guess I want to press Carl in the end to talk about a global perspective and not kind of from one country, because there are scientific spillovers across countries, and science is a body of knowledge that's complex and progressing over time. And so, when we think about how we're incrementally adding to it for rewarding innovation in specific areas, is that too narrow a perspective? I guess would be my question. Yeah.
Okay, I sent you an email. I've the threshold. It was.
So we're
No. I sent it. I sent it to Beverly.
Anirban, do you want to jump in?
So I do have just a clarification question for Carl. You mentioned something about the Lomas paper, about how it's not applicable. I was wondering if you could expand on that.
Go get my laptop.
We're sorry. We'll get to those questions in just a sec.
This one?
That's the one.
Yeah.
Okay.
Sorry, Anirban.
So,
Hey.
Anirban, ask your question again. We'll take a short pause to answer that.
I think Carl just went quickly over that, but the slide with the Lomas's studies results were there. I think you mentioned something about those results are not applicable for this purpose or something like that, and maybe I heard it wrong. But if you could expand on that, that'd be great.
Yeah, so I think with I was just going through the results from the UK, and I think in the UK, the appropriate measure of health opportunity cost with a single payer system, whether it's administrative budget or not, is estimates of marginal productivity, particularly if there aren't budgetary silos on categories. I don't think that's true of private plans, and I'm kind of going to get to that. But I think the work that we've been doing, there's two elements to it. One is estimating for all waves of data, but then challenging that with a different approach to identification, which we've done, and we get the same answer. The other work with James was about non-marginal budgetary impacts, and that gives you a result that you'd expect, which is diminishing marginal returns to healthcare expenditure.
Mm-hmm.
Okay. So yeah, it's not just in the UK that have been using within country data to try and estimate this stuff. This is just the estimates that are currently out there. I won't go through them because I know I'm pushed for time, but they're there, and they're getting out in journals, and there's more work underway around the world. So this is kind of the big boulders started rolling down the hill, and anybody tries to stop it, there's a Bob Dylan song about that. Don't stand in the hallway. Don't block up the door. What might our UK work say about the rest of the world? Well, this is some initial work. We knew it was crude, but said, hey, what if we're kind of right in the UK? And that means it's about half a GDP per capita. And what if any discrepancy between what people are willing to pay for health and what our healthcare system is delivering, that discrepancy, in other words, the kind of underfunding, if you like, of the healthcare system, if that's similar around the world, that's my fault. The numbers should be there, but you're going to see them later. If that's similar around the world, and what we know about income elasticity of demand, this wasn't based on Chuck's work, because Chuck's work's too recent for us to have used it. If it had been there, we'd have used Chuck's work. This is based on some of the empirical work around income elasticities. Then these are the implications. Now, Norway, the Nordheim Commission basically used this work to set their basic threshold in Norway. It has implications in this case for lower middle income countries, which is why we did the work. It also has an implication for the USA, but I forgot to add them into the slide. I'll show them you later. The other way to go and think about thresholds around the world is to look at the literature that's estimated the mortality effect of expenditure based on country level data. Now, much more challenging to try and estimate that, particularly with the kind of instruments that are available, but that literature exists. There's a lot of papers that have tried to do that. This is based on a particular paper that we think is a really good example, basically because of the way the instrument, and they are instrumenting not just one, but a number of things in there. It's by Bakori, and he was generous enough to give us his data, so we were able to re-estimate everything. And these are cost per DALI averted thresholds for lower middle income countries. On the x-axis is under 5 mortality, and exactly what you would expect. Where you've got an awful lot of mortality, cost per DALI is really low because there's so much you can do with a small amount of money. There's another way to look at it, which is we can look at it for low income countries and compare these estimates to GDP per capita. The rise in solid diagonal is what it would look like at 1 times GDP per capita. So what you can see is why WHO was so wrong in promoting 1 to 3 times GDP, which has done huge damage to some of the poorest healthcare systems in the world. You're looking at the reality of global health inequality. This is what it looks like for middle income countries. Still, generally less than 1 times GDP per capita. Again, forgot to put the USA numbers on there, but you're going to see them in a minute. This is work we did for Canada, for the Patented Medicines Price Review Board just last year, who are very brave and doing the right thing. And there's 3 columns, and it's basically taking estimated elasticities that we've got either from the UK work, our work, Andrew's work, a very important paper, and Bakori that uses cross-country data. We apply those elasticities to what we know about the demographics and the epidemiology in each of the Canadian states, and that's kind of what you're looking at there, right? That's what it looks like for the United States, the same analysis. Again, James, Jessica did this. So, that's going to make somebody's eye water, $16 per quality. Why is it so low? Well, it's so low because we've got a very high elasticity in the UK because our healthcare system is really productive and really efficient at the margin. And we probably spend too little on healthcare. But also, America has got a young population that face very high mortality risk conditional on that demographic. That's the truth. And so any small proportionate effect has a big effect on life years, deaths, life years and qualities in America because you're young and you're really unhealthy. So what are the health effects of additional healthcare costs in the USA? Well, in a single payer healthcare systems, what you need is marginal productivity estimates, just like in the UK and in other countries. And you have single payer systems. You've got lots of them. You've got 50 Medicaid programs, as I understand it, 50 single payer systems, all federal or state funded, come from taxes. You've got veterans, which I understand is federal. You've got Medicare. Now, Medicare aren't allowed to make any decisions anymore. And I've got total admiration for the heroes that work at CMS, only allowed to use pencils, and the computers that are bought for them couldn't land Apollo 11 on the moon. But you know what? They can't make decisions, but it can't be good to know what you're getting for your federal dollar, and maybe one day some politician somewhere, some savior arisen from the streets will start to allow Medicare to make some decisions again. What about the private plans? What we need to know are the health effects have been priced out at plan choice or at point of care. We need to understand the cost net of the copay and whether they're going to be passed on. If there's going to be copays for the new drug, that's going to have health consequences at point of care. It's going to have consumption consequences for Americans who might have to sell their house to cover the copay, and it's going to have federal dollar effects insofar as people have health savings accounts. I'm dyslexic, got the acronym wrong. What about employers and employees? Well, they might decide to stop offering or buying coverage that has got, it's got lower coverage options. That's going to have health and consumption effects. Employers and plans might try to control costs by reducing benefits or putting barriers in the way of access. Yeah, it's on the formulary, but you know what? You've got to jump through so many hoops, you're going to be dead before we have to prescribe it. They're going to increase co-pays and deductibles. That's going to have health consequences. It's going to have consumption consequences, and it's going to have federal dollar consequences insofar as people have health savings accounts and other subsidies that are offered by government. So health and consumption effects are going to be greater generally for lower income and those in greater health need. I haven't got the data, but I haven't got a third testicle to bet, so I'll tell you what, there you go, have a kidney. Is it possible to estimate this? Yes, it is. Proof of principle, Dave Van Ness, I hear 2017, absolutely. Got stuck in, took what was available and put it together in a sensible and coherent manner. We need the proportion insured. We can reasonably assume 100% pass-through, but you don't have to. Tell me what your pass-through is. The elasticity of coverage with respect to premium changes. How do people respond to premium changes? What proportion fall out of coverage? We've got data on that. We know we know something about the mortality effects of losing your coverage. And so we can transform those mortality effects into life years and adjust them for quality based on age and gender. What about morbidity effects? We know something about the morbidity effects of losing your coverage. So we can adjust for the quality effects of those that survive losing coverage. And so we get a cost per quality that represents opportunity cost. And guess what Davy's number is? It's £100,000 per quality.
Why do you think that's so much higher than or $16,000 extrapolated from the UK?
Because in the UK, all opportunity costs are health opportunity costs because we have a single payer, community rated system, right? And we've got an administratively fixed budget constraint. In the US, there's two forms of opportunity cost. You're going to pay with other people's health. So nobody pays for their own healthcare. You have access to a new medicine, you don't pay for it. You might pay an eye-watering copay, but it's only a proportion of the actual cost. There's two communities that pay for your drug. One is the people who drop out of coverage and die. The other people who pay are the people who stay in the plan and suck up the higher premiums. So part of the opportunity cost is being sucked out of consumption and people's ability to pay their rent. Do you get me?
I think so, got it.
If it was all forced to be on health,
Right.
this would be a lot lower, even though you're a rich country.
Okay.
Histogram, Dave, and he's working with James, hopefully putting the paper together soon. We can look at the uncertainty. I'm not going to labour this. These are the key parameters in the model. Yeah, sensitivity analysis. Guess what? Over a range of distributions on these parameters that kind of bound kind of insanity to mania, it ain't less than 50 and it ain't more than 150. So, what are the health effects of approving a new drug? This might be a bit sketchy because I did it about an hour ago. Fueled with coffee and excessive nicotine that could kill a bull elephant. But basically, this is the way I think about the effects. The first column is the new drug. We've got a new drug and it's going to gain you 1 quality per patient treated, but it's going to cost you £200,000. You've got a 20% copay, 10% of your enrollees, or the probability that this patient has got a health savings account is 10%. I'm not going to go through it all, but basically we can just set out how it pans out. Now, if you use Dave's estimate of health opportunity cost, the opportunity costs are 1.6 qualities. You gain 1 quality, you lose 1.6 qualities for the people who dropped out of coverage as a consequence. The other part of opportunity cost, though, is the other people who are going to pay higher premiums. And so In that column, you've got 2,222. I mean, based on made-up numbers, we've got 100 patients eligible. I've got 1,000 enrollees, and that's what would have to be paid in the next round. Once we've taken account of the fact that some people will no longer be around because they're going to drop their coverage. So instead of having 10,000 enrollees, you've got 9. Anyway, the details don't matter, but at least you can start to set out both the health consequences, the consumption consequences, and the impact on federal dollars. Because federal dollars are not the same as private dollars. Federal dollars are more expensive to get. There's a literature, public finance literature, that tries to estimate the marginal cost of public finance. In the UK, the estimate is somewhere between 1.3 and 1.5. In the US, you've got a less progressive tax system, so I don't know, it's going to be 1.2, something like that.
Carl, before you go, I know these are all assumptions, but the probability of dropping coverage is 10%?
No. So that's a made-up number, and I was doing this an hour before. Right. The truth is that the probability of dropping coverage can be derived from Dave's work. Right. It's just it's not an easy thing to. Yeah. Okay. So forget about that number. It's just I picked it.
Got it.
Yeah.
Just make the point that the opportunity cost, no matter what that probability of dropping coverage is there a threshold number at which the new drug?
We could do that. We could do that.
Would have to be.
We could do that. We could do that. You're absolutely right. In this case, the reason why you lose more health than you gain is because I've got that probability in there. If I reduced it, I could make it go below.
Got it.
Now, just because of the way David's paper's written, I couldn't crank out the probability. There wasn't enough coffee at ICE's very lovely coffee station. I did try, but it wasn't sufficient.
The opportunity cost of more coffee was just far.
Yeah, well, we might need to get a Class A drug in here, and then we'll be really productive. Okay. So, what else do we need?
Within about 5 minutes, do you think?
The last slide.
Oh, awesome. Go ahead.
So, what do we need to make this mission? And it is a mission from God, but at least ICE has got more than half a tank of gas, in my opinion. What else do we need other than an empirical assessment of health opportunity cost, an idea about the consumption value of health, which should indeed be based on Chuck's paper? In the last webinar, I made a terrible mistake. I had read Chuck's paper, but I'd read it through the eyes of an old theoretical paper by Gravel and Smith in 2001. They do it slightly differently. Chuck's paper is bang on, simple. All you got to assume is that you have a measure of health-related utility. Now, are qualis utility? No, they're not. Are they a reasonable start point? Yeah. And you know what? Gravel and Smith and Chuck, same answer. Both theory-driven, different start points, income elasticity demand for health. It's about 1. What else do we need? We need courage. These are Steve's words, but my interpretation. We need courage. Well, you know what? If you're on a mission from God, you need a hearty breakfast, you need a lot of coffee, and you need unlimited access to nicotine. But then you need courage. And that's courage to say, we use estimates of health opportunity cost because you do not pay for your healthcare. Other people do, sometimes with their lives and the lives and dignity of the ones they love. Honesty. What does honesty mean? It means tell the truth. The truth is, the K's and the V's differ across your healthcare systems and plans. Now, you can tell a different story if you think that's going to make you sleep well in bed, and that's fine. Life's a trade. Tell the story. It's okay. But just so you know, by telling that story, you're going to reduce health outcomes overall. You're going to force those who can afford it least to pay too much for their healthcare, and you're going to impoverish those already struggling with their bills, their non-healthcare bills, to continue paying their rent. That will be the consequence. But maybe you'll get a good night's sleep. If you can afford the AC, that is. What should we do? In my opinion, we should tell the truth. We should reveal the implications of current arrangements and add to the accountability of those responsible for them. What's the last thing we need? We need humility. There is no such thing as a decision rule. There never has been, there never will be. You know what? The algorithms are not going to take over the planet. Things are the way they are because human beings made a decision to make them the way they are. There's no rules. There is no decision rule. I tell you what there is. There is the possibility of accountable decisions, and that's what I witnessed last week with ISA. Accountable to reason, to evidence, and reasonably held, but yes, disputed social values. So, that's ISA's mission. Who is the mission for? First and foremost, maybe it's for those that are responsible for making decisions on other people's behalf, because all healthcare decisions are not individualistic. Unless you're rich enough to pay directly for your healthcare without insurance, and you're an MD and you're fully informed. Aside from that, somebody else pays, and so somebody else has to make a decision on your behalf. So yeah, for sure, the primary audience are those responsible for those choices in the private plans, deciding how to sort out coverage, sort out access, sort out what's on the formulary, and sort out what kind of discounts are required to make this work. But that's not the only audience. The other critical audience is patients and their carers and loved ones at point of care, facing difficult choices about selling the house or not getting access. It's also about consumers at plan choice, being better informed about what's on the table. And it's also about citizens deciding to hold those to account who have brought us to this sorry pass. In the words of Forrest Gump, that's all I have to say about that.
Thank you, Carl. That was magnificent. Thanks. So we have Lou Garrison and Anirban Basu with us to provide some commentary, response, if you will. And they didn't get a chance to see the full deck of slides beforehand, so part of this I'm sure will be ad hoc. But Lou, why don't I let you go first, and then we'll move to Anirban afterwards. Lou, are you there?
Yeah, I'm turning my microphone.
Great.
As has been said many times before, it's very hard to follow Carl Claxton in a talk, but so I won't attempt to sort of make this to deal with all the issues. But I wanted to talk about opportunity cost as a basis for the U.S. cost effectiveness threshold. And again, this webinar series is really Steve Pearson and colleagues at ICER trying to say, how can we triangulate with the literature and think about a threshold to be used in ICER's deliberations, which, as we all know, that they seem to be settling on 150,000 per quality for sort of a value-based price, which then influences discussions in the private sector market. By the way, I'm at the University of Washington with Anirban, who will be speaking next, and my colleague Sean Sullivan. I'm also a visiting senior fellow at the Office of Health Economics in London. So next slide, please. So again, I really want to thank Carl and his colleagues for this body of research they've created. I mean, Carl makes a very persuasive case that we need to think about what we're giving up when we spend more money on healthcare. And I think we can look at that question very broadly in a healthcare system that, spending 18% of GDP, far more than any other system in the world. Now, McCabe spoke about a demand side threshold and a supply side threshold last Wednesday, I think. So I'm thinking about that margin between health spending and other things. And so what are we giving up when we devote more to healthcare? And I think that's the idea of opportunity costs. And we need to, in a very pluralistic system, it's very complicated to get at that answer, because even if we look at the private sector market, and by the way, I have not seen Dave Van Ness's paper, but that's the driver of the system in a sense, and I'll make a comment on that later. But at the same time, we then end up grandfathering in, to use the term, that technology for the Medicare population. So so we really need to know, well, what's the threshold for the Medicare population and the opportunity cost threshold? Now, I said the other day that willingness to pay, and that's what we were talking about last Wednesday, is a reasonable way to think about these things in our consumer sovereignty-based welfare system. So we're basically, I think I take a Rawlsian perspective, sort of saying, well, what would I have been willing to pay before I knew which person I would be in the U.S. healthcare system in terms of premium and taxes and so on. But we also can look at opportunity costs and what other things do we give up. And it's been mentioned that when we think about the ESRD program, the kidney dialysis program in the U.S., the estimated cost for the hundreds of thousands of people there is about 150,000 per quality. So from a revealed preference point of view, in a Medicare population, we're spending above that 100,000 that we're talking about in the private sector. We all recognize that value from this welfare perspective and opportunity cost, what people are willing to give up, varies across individuals. There's heterogeneity there. The value will vary by indications for the same medicine, so you might want to have indication-specific pricing. And it will vary over time as we learn more about how the medicine works. And as you know, we all know that price that ICE are speaking to is what's negotiated at launch. And Patricia Danzin spoke eloquently to the problems with our system after launch and how market power leads to a divergence between value and price. But I want to emphasize that it's important. We're talking about 10 to 20% of the budget in the United States. Now, Jens talked about that the U.S. essentially is funding the bulk of global innovation when it comes to medicines. But these have global public good properties, so that it's science, and over 7 billion people can benefit, as we've all seen in the area of HIV, where the medicines invented for the developed markets have spilled over into the developing markets and saved millions of lives. Now, the patent system is a prize system. Carl laid that out, that you get and maybe the prize is too big, but the prize is you get to be a monopolist for a limited time. Newhouse said in 2004, the effort here is to approximate a dynamically efficient price. Now, I would say that it's a crude approximation. Why the same patent length and so on for every product? Certainly in our field, there's been a strong economic case for differential pricing going back to 2003. And also, as Carl said, differential pricing across individuals and different subgroups of the population. Next slide, please. So I won't say a lot about the really impressive monumental econometric effort and modeling. Modeling. Carl they've been working for several years to try to address what are seen as limitations. There are measurement challenges has been laid out by the Office of Health Economics in the last couple of years. But a lot of this relates to the quality measurement, but as Carl said, they're trying to tackle that. It's going to be difficult to replicate this in the U.S. And again, given that we don't have the same kind of data set across geographic areas that Carl and colleagues are using, we're at 18% of GDP, and yet we have worse mortality outcomes. So we know at the margin, our spending doesn't look very cost effective. So what are we maximizing? Well, there's certainly a literature saying that we're maximizing. It's the price is stupid, according to Reinhardt and Anderson. People capture more of the rents, but yet we're not actually getting more hospital days or more care, more doctor visits. Now, as we all know, we're heavily distorted by the tax subsidy for employer-based insurance. So these decisions by the driving private sector are subject to a subsidy. Hence, it's not a surprise that from that point of view, that we're a much higher level of total spending than other systems. Now, our ISPOR Special Task Force that I mentioned last week talked about a broader concept besides the quality. We talked about basing things on the quality as the health gain. But when Carl talks about losing insurance coverage, you lose peace of mind in particular. Let me emphasize that one. So that's insurance value. We talked about that. And the other one I want to emphasize are these broader systems, equity issues that need to be considered. And we are in, a system with tremendous inequality in income and wealth. But yet the scientific spillovers is the idea of externalities, that this science is a collective body, and that knowledge is spilling over to many different areas and many different parts of the world. So next slide. That's my final slide. So I think it is going to be difficult to measure these. It's not as though we've never thought of this. I can think of a paper in 1998 with Jack Hadley estimating relating mortality rates in the elderly to Medicare spending. We got to remember that we don't have a fixed annual budget. We can borrow from future generations, as both the U.S. and UK are doing. Carl and Mike Pauldin have a nice paper talking about we need to think intergenerationally. How does the threshold change over time, over generations? And especially if we're borrowing from those generations. So you need a bigger model, and we need to think about the public goods aspect of these medicines that are benefiting, that really benefit everybody in the world. And we're all being asked to sort of contribute to that. And so you need to not take an individual country perspective. So what should ICER do moving forward? Well, what I suggest is that they really should continue to support and encourage this research on opportunity costs. And in particular, I think we're all aware, we ask in the Medicaid program, which has budgets, and states have to make hard choices, what choices are being made. But I also think when it comes to thinking about specific diseases, the work of our task force and Lakdawala and Phelps really highlight the need to think about how that threshold might vary for different diseases. So I'm saying we need to think about this science globally, okay, and we need to think long term. And I'm fine to do this with courage, honesty, and humility. And I would underscore Carl's comment that we have disputed social values as we're dealing with in Brexit in the UK and our what's happening in the US at the moment. So it's a big challenge for us to deal with this. So thank you, Steve, for the opportunity to speak.
Thank you, Lou. That was great. Given the time left, why don't I let Carl have maybe a 1 minute response?
I'll pass.
You want to wait until Arbon?
Yeah.
Okay, good. I just wanted to make sure.
I enjoyed losing. I've got a lot.
Let's see what Anirban has to say, and then we'll circle back. Anirban, please go ahead.
Yeah, thanks. So I am doing this, more ad hoc than Lou, I guess, but always a pleasure to hear Carl talk about these things. I think the general notion that, in terms of access versus innovation, is that we are dealing with a trade-off, and the trade-off is between maximizing current consumer surplus versus the consumer surplus of the future patients, right? And somewhere in between, we have to come up with some, not necessarily a decision rule, but something that could be defensible in terms of how we make that trade-off. And that's where I think the cost effectiveness thresholds comes in. It's not a single number because there are many other dimensions of value that we care about, but at least if we have a range, we can make some informed decisions about what to cover and where to let go current consumer surplus in terms of future consumer surplus. I do think that the decision making about maximizing health in a society should account for beyond just the health opportunity cost, because in the simple sense, if you pay $10 to get one QALY, that QALY can give you at least one GDP. And from a purely societal point of view, you are better off because you have recuperated your cost of investment, and you have got 1 unit of health. So under no circumstance that I see that if you're trying to maximize health, but you're taking a societal perspective, that a threshold could ever be less than 1 GDP. Now, as Carl mentioned, that if you're just looking at health opportunity cost versus the social opportunity cost, that threshold could be lower because you are dealing with what other health would be displaced by other technologies. But from a societal point of view, it's very unclear as to, from a theoretical perspective, why the threshold would ever be less than a GDP. In fact, the empirical examples kind of estimated show that the income elasticity is close to 1, and most of them are based on individual elasticities. I mean, if you're taking about social planners utility, it might very well be more than 1, just purely maximizing QALYs from a societal budget. Now, from the analysis that I kind of Carl showed in terms of the opportunity cost and even the health opportunity cost, and across different countries. The one thing that has always bothered me for that analysis, and I'm meeting Carl this week, so we can have a lot more discussions about this, is that it seems to me that when you estimate the health opportunity cost using a particular method, the instrumental variable analysis that they employed, you are answering the question as to whether you should be increasing the health budget in a system. In fact, a lower opportunity cost means to me that you are under investing in health because under random conditions, if you had increased the budget, people were using a lot more cost-effective technologies, and that's why you're getting that lower opportunity cost. And so to me, that tells me in all these low-income and developing countries that the health budget is not sufficient, and increasing the budget would actually lead to more use of cost-effectiveness technologies. And I'm happy to debate about that, about why I think the interpretation of those results answers the question that whether it should be increasing the budget versus what the threshold for a new technology should be. Um, I think in general, Dave Vanis's work is the best we have for the US. There are two things I would say about that. One is, it is an estimate that is derived based on pulling together parameters from very different systems. For example, the elasticity was obtained, I think, from private insurance. Some of the utilizations were obtained from Medicaid, and these are very heterogeneous population. But as in a simulation model, he pulled them together and estimated these thresholds. The one thing, though, to be very clear, that estimate is a societal threshold. It's not a health opportunity cost. It's not a cost of any particular healthcare system. Um, and if we were to use, and I think we should be using those kind of thresholds and the variation that Carl showed in terms of that, we also have to make sure that when we evaluate new technologies like ISA does, that we are also taking a societal perspective in doing so, because it'll be weird to have new technologies measured in terms of only health production and then compare it to a threshold that is meant for a societal decision-making threshold. How we get there, obviously, the second panel have laid out a lot of recommendations about that, and we can certainly need more work in making sure that we have standard methods and incorporating all the other effects into these analysis. But there has to be some consistency in terms of how a decision-making threshold and the analysis of cost effectiveness needs to happen over time. Finally, I think in the US, it's different plans may have different thresholds. And in the ideal world, as Mark Pauly said, you could have different plans setting different thresholds and charging a different premium from different people, and it'll be a competitive system. But I don't see any time that kind of competitive system evolving as a result of different plans having, estimating their threshold, within their system. I mean, it's hard enough estimating one threshold given all the data. So I think we need to understand that we need some basic kind of benchmarks to kind of deal with it. And as long as we are within the benchmark or below those benchmarks, we are being kind of prudent custodian of our limited resources. Anything above that, we need to have a very critical view of what else we are giving up in order to cover those. The access part is interesting, because to one extent, if we do increase access, then obviously you increase healthcare budget. But if you do decrease access in terms of saying coverage no, then you have all these other externalities that people are buying, selling off their home, or they're becoming delinquent. So it's really this double-edged sword that you can think about. Yes, we should be giving access broadly, but again, on the other hand, giving access broadly means that there could be an effect on the premium, and reducing access means all these other externalities that happens. So we need to have a balance between those two. So I would stop there, and happy to discuss further and listen to Carl and Lou.
Thank you very much, Anirban. That was great. Now, there's no actually hard stops that we have. I know many of you may need to leave for whatever appointments you have, but we're going to go ahead and let Carl respond in maybe up to 5 minutes, and we'll wrap that up as part of the webinar. So thank you very much, Lou and Anirban.
No, thanks. Carl, thank you, Steve. Yeah, I'm just going to pick things up. They're not in any particular order. What I'd say, Anirban, is I totally agree with you, and our work is not about simply what you should do when confronted with a new patented technology in a single payer administrative budget. The work's much broader than that, and we've tried to cast it that way over recent years. That really, this work is telling you something about whether you want to increase expenditure on healthcare. That's really what it's about, and that's what I care most about. And that's true in the low and middle income countries. And that's exactly the way we used the work when we were working with the Ministry of Health in Malawi. There's a paper in BMJ Global Health. It was Jessica O'Hallett that was doing that work. And the estimate that we had was a dali costs you $60. And on the way to Malawi, I realized I'd forgotten my tie in Terminal 5. And I had to go and buy a tie. And guess what? A tie in Terminal 5 can avert a dali in Malawi. Now that is appalling and shocking. And in a way, this work is about exposing those facts with a view to saying, look, actually, you're getting an awful lot for some relatively modest amounts of money spent on healthcare. The truth is, Malawi is so poor, it can't really afford to spend anymore. But it is a call to arms for donors, and also holding donors to account. A, that you're not donating sufficient funds, and B, when you do donate it, you're assigning it and tying it to cost ineffective care in those countries. And then, of course, I think this is true in high-income countries too. So, for example, we voted for less than £15,000 equality. That's what we collectively voted for. Now, we didn't vote for it because the citizens didn't know that it was only £15,000 equality, and the NHS is fantastic value, and maybe it was worth, raising some more taxes or borrowing some more money to spend a little bit more. So I think that is exactly where it's at. It's not just this kind of technical, kind of geeky question. It contributes to a much wider social debate about what we want as a society. On the GDP and equality, I find that quite hard. Let's be clear. GDP is not a measure of welfare. I mean, GDP is just some arbitrary, pretty clunky national accounting that misses out on so many important things. So I wouldn't want to nail any welfare claims to some nonsense GDP.
So let me explain what I meant by that. GDP is not a measure of any willingness to pay. I understand that. But if a social planner is trying to maximize health subject to a societal resource constraint, GDP does play into that societal resource constraint.
Yeah. Annabelle, I think.
Yeah.
Well, I don't view this as trying to maximize health, because you don't want to maximize health because there's lots of other things you need to do, like pay the rent and your electricity bill in Boston when it's super hot, so you've got some AC. It gets. I've got so hot these last few days. I'd have definitely traded a few months of my conditional life expectancy for, getting some nice cold air on the back.
But you do agree that the CEA is trying to maximize health, right?
No, I don't actually, Annabelle. I don't. Listen, this is one for a beer. But listen, can I tell you something else? Which is actually, the truth is, because we did it with the Department of Health for the net production slide. Truth is, over your life cycle, actually, it's a net loss. And that shouldn't be any surprise. It's a net loss for almost everybody in high-income countries. Why? Because we're borrowing against the future with our expectation that economic growth is going to take care of it. Actually, if we fall off the edge of the cliff, then it's Armageddon. But can I just have a couple, just a tiny go at Lou? I totally agree. I would like to see a world where we can have price discrimination between healthcare systems, across indications and across subgroups. That would be amazing. And I would like to see reference pricing and parallel trade on branded pharmaceuticals become a capital offence. I would so like to see those mechanisms, and I believe we could put those mechanisms in place. And I agree with Newhouse. Patents are a pretty clunky way of trying to get at dynamic pricing. But I don't know if you guys can see the slide up. That dynamic pricing needs to be sensible. And we don't know what the share should be, but we know it ain't zero and we know it ain't 100%. And at current prices, by and large, we're giving away more than 100%. And that cannot be right, no matter what you think the dynamic effects are or how good you think that global public good is. So at current prices, we're not producing public goods, we're producing public bads. We are incentivizing the production of medicines that are unaffordable. Now, that is a terrible situation because it is such a social waste of intellectual resources and resource that could have been put to better use, whether healthcare or producing more efficient air conditioners, I don't know, anything you want. But it's also really bad because it is creating a situation where patients know and if this innovation exists, it could benefit them, their loved ones, their families, and they can't afford it. You know, we are spending money creating expectations of regret. People don't pay for hope, they pay to avoid regret. There's an easy way to reduce your expected regret. Don't produce stuff that people can't ultimately afford to pay for. So Luke, listen, I believe we should behave like good citizens, and a good citizen gives up to Caesar what is Caesar's. The question is, what is Caesar's? Caesar can have the maximum monopoly price, and that's the P star on the first slide, but no more. Now, if we wanted to get smart here, we've got fixed patents, we can't have multiple patent lengths, but what we can do is to make sure that we agree on what the optimal share is, and we can do that empirically, and then we can dial up or down the threshold or the decision threshold or the threshold by which we decide on discounts to make sure that all different kinds of products are getting the appropriate share. And it means for biosimilars, you're maybe getting paid less than actually opportunity costs. For those products that are about high prevalence, low incidence, chronic disease, maybe you're getting less than opportunity costs. But you know what? If you're producing something like for antimicrobial resistance, where we expect a rise in incidence, we're going to pay you a hell of a lot more than opportunity cost, because we know that all the benefits lie in the future when you've lost your patent, and we want to make sure people come into the market to deal with those really important things. Right. I'm definitely done now.
All right. Thank you very much. I wish we could continue on with a longer debate, but I know that these webinars will certainly, hopefully, spur those debates among many folks in the future as we are recording them. So we'll look forward to hosting the last one of these on August 1st. I will present a non-economist view of some of the issues that have been raised in the first 4 seminars, but thank you very much. We'll see you then. And thanks to Carl.